don't I owe tax on, you're going to hire a bookkeeper, you're going to pay more to do just the paperwork on that, let alone the cost of the tax. And so in an ideal world, we would get rid of the whole GRT on healthcare, on medical services. That's a big chunk of change. And so what we're aiming for is just getting rid of the co-insurance piece of that, which is a large piece. That actually passed both the House and the Senate last session. The governor vetoed it because there was not a way to pay for it in that bill. So hopefully the legislature can come up with a pay for and get that done. It has been introduced as Senate Bill 13. It was presented in Senate Tax this morning or this afternoon, and it got a relatively favorable reception. We'll see if it gets included in the legislation that goes to the governor this session.
Does New Mexico receive a lot of revenue from GRT on medical services?
We receive a lot of money from GRT, period, but medical services is just sort of one small piece. So because the gross receipts tax is essentially our sales tax, and we don't get all that much money from income taxes, we don't get all that much money from property taxes, that sales tax GRT piece is a very large portion of the state budget, and so that has been challenging when we're trying to say, we should take it off of things like food and medical services.
Yeah, and just to add to that, our entire tax system needs to be reformed, but that's a whole other 505-o-matic episode. But
not if no.
not do that. But all of that to say, I do try to apply the same principles from at least my version of what the tax system should be like to this conversation as well. I still feel really strongly about making sure that these corporations are paying what they need to because they owe something to our community. But once again, where I draw the line is how are we supporting our independent folks, our local positions, etc. Because we really need to ease some burdens on that for sure. But also, I'm sorry, corporations have a lot of money and they keep making money, and to exempt them from these things is just not fair.
And I'm just going to comment that all of the medical billing is so very complicated, and trying to figure out which codes we need to put in is why I am not doing adequate counseling on why people should be exercising or, making sure that they have their cancer screening, because I'm trying to figure out, do I use this CPT code or this one? And it gets very confusing.
Yeah. Okay, last, we want to touch on Medicaid. You want to go to the first bullet?
Oh, sure, yeah.
So New Mexico has a higher proportion of our population insured under Medicaid than any other state. I believe it's 42%.
Yes.
So that's 2 out of 3. What is the statistics? 2 out of 3 patients are on Medicaid? No. 2 out of 5. Thank you. So, yeah. So many providers are breaking even or losing money because of how Medicaid is reimbursed. We don't have to go into it too much, but some of the legislation being proposed is around reimbursements. Is that correct, Anya?
Definitely, and we've raised Medicaid reimbursement rates a substantial amount, and I will say we are actually, I believe it's number 1 or number 2. I always forget. We probably go back and forth, but in terms of our Medicaid reimbursement rate in the nation, we are the highest or second highest in the nation. And the reason I point this out is because, I am always going to vote for making sure that we have higher Medicaid reimbursement rates. But if we're not addressing the root problem, which is the fact that we have so many people on Medicaid, we are only putting a Band-Aid on the situation. And I'm happy to put this little Band-Aid on, but quite honestly, the people who, the same people who don't want to disclose all their corporate shenanigans are, the same people that are not wanting to raise the minimum wage. They are the same people who fought against paid family and medical leave. They killed the bill, right? And so when we're talking about Medicaid reimbursements, I want to once again bring it back to the people who are on Medicaid, and what are we doing to make sure that they are no longer on Medicaid? So anyway, I feel very feisty and passionate about all these things. But I think it's really important as we have the Medicaid reimbursement conversation, because we are number 1 or number 2 in the nation.
Dr. Hayes, do you want to speak to this?
I just want to say, make sure you phrase that we want to have people not on Medicaid so that they can be on other insurance.
Correct, thank you.
Federal not passed a lot of laws that will take on a lot of people off Medicaid, but not the way that I was hoping for. So.
And they will take you out of context and cite you.
100%. Yes,
Yes.
thank you.
But we are looking at losing probably, our largest source of income is from Medicaid. And we think about 40% of our patients will lose Medicaid with the cuts. And this means we will go from getting an average of $200 per visit down to probably there will be self-pay between $15 to $45. So it's going to be a huge cut to federally qualified health centers. And it's also going to be terrible for care. I remember before we had Medicaid and ACA so readily available, I would see patients much more often with end-stage diseases because they couldn't come in because they couldn't afford the co-pays, they couldn't afford medications. They knew I was going to recommend that they get on medication for their diabetes and they couldn't afford it. So, you know, the cuts at the federal level on the eligibility are really going to be devastating to New Mexico.
So this bill, Senate Bill 9, would appropriate $1 billion. $1 billion? I'm just looking at that. Wow, $1 million in one-time funding.
Billion.
For the Medicaid Trust Fund. And so this money would then help cover, how does this work?
Sure. So last year, the legislature created the Medicaid Trust Fund. Legislature's done a great job over the last several years of creating permanent trust funds out of these one-time monies. So New Mexico has been very oil and gas dependent. And one of the smart moves the legislature has been doing is saying that's going to run out, right? That we're not going to be in a boom forever. So let's take some of those one-time monies and put them into essentially endowments. So we now have this wonderful endowment for early childhood education. We have one for higher education, one for conservation. And last year, there were 2 created for healthcare, one for behavioral healthcare specifically, and then the Medicaid Trust Fund, which was the one that I think New Mexico worked on. And it got some initial funding, a few $100 million. And then, of course, the federal cuts hit. And the federal budget bill is devastating on so many levels. It's going to unfortunately force us to roll back some of those reimbursement rates, which we had done so much to get up higher. It's just going to be very, very problematic in terms of the cuts to the states. So our thinking is let's get some more state money into this Medicaid Trust Fund so that it can generate recurring funds year over year and pay some of those Medicaid costs and fill some of the holes. And so Senate Bill 9 proposes $1 billion of one-time money into that Medicaid Trust Fund. That would spin off about $50 million a year, matched 3-to-1 by the feds would be about $200 million a year. We'd like to get it up to $2 billion, spin off $100 million a year, get to $400 million. So it's just a nice recurring source of funding, so we're not dependent on sort of the boom bust of a budget cycle, because we know this is essential. Having 42% of the population of Medicaid, it's kind of like good news, bad news. Like the bad news is that's a lot of people that should be on better insurance. That's a lot of people that are paying at doctors sort of like a break-even rate rather than what sort of private insurance would pay. But it's good news in that they're not uncovered. They're not uncompensated care. So we want to sort of keep this threadbare system as together as it can. And so investing more in Medicaid is going to at least hopefully keep some providers able to keep their doors open and keep treating Medicaid patients. Because what we don't want to see is Medicaid patients losing access to care.
Yeah. Well, I think we got to move along because we got to get some audience questions.
Exactly.
So we'll quickly go over the problem areas real quick. So yeah, we just to recap, there they are: medical malpractice, interstate compacts, student loan repayment program. It's not a problem. That's what we're going to do. We're going to address these things. Grocery tax on medical services, Medicaid reimbursements, and I'm going to say it's more than a dash. Now it's a big part of the issue, and so we are going to take some audience questions, and we unfortunately do not have any time for personal stories. Does anyone?
But we do have one of our team members outside, so if you do want to share your story, which we would love to hear, she's set up out there to record your stories, so you can stick around, or actually we might do it in here, so yeah.
Great.
But for now, we'd like to open it up to any questions from the audience, and we've got a hand over there.
Yeah, I don't know how the legislature can do what they are expected to do in 30 days. This is the big problem.
Can you speak?
The state of New Mexico is so far behind. I've been here for 30 years.
Is it on?
This doesn't work. But how do we expect our legislators to do what we expect them to do do when they only have 30 days, and if they are given a special session, the session doesn't last probably more than 2 weeks. So I would address that to you.
Damn right. I don't know what to say. No,
How can we
it's a
change
problem.
this?
Okay, actually, okay.
I'm
There's
going to repeat the question for the live stream
Yes,
real
okay,
quick. So the question is, how are you going to do all that in 30 days?
Woo, hot dog. I love this question so much. Okay, there's actually some hope, and I'll tell you about that in a minute. But we are also the only unpaid legislature in the entire nation. So we are all volunteers. We do this year-round, even though we're only in session either 30 to 60 days. You are completely right. The fact that we are cramming this into 30 and 60 days is insane. Clearly we work year-round, but I think the real problem here is that we don't have a professionalized legislature. And I talk about this not just when we're talking about medicine, right? Because I am all about oversight, transparency, accountability. But I'm also like, when we're talking about like CYFD, I'm like, if we want oversight, then we need to have a professional legislature because we are the accountability arm, right? And so for me, like when I talk to constituents about having a professional legislature, even if they start on the other side, like where they're like, well, why would you want to pay yourself? And I'm like, first of all, like I don't really like working for free. It's not the best, but I do it because I think it's really important. And I will also say that when we start talking about oversight and accountability, which I think everybody wants, especially when we have these like really big problems to fix, nobody wants a hodgepodge like volunteer who can do it when they can. It's a big problem, like regardless whether we're talking about healthcare, whether we're talking about whatever other topic. And so I will also just add in that we are the highest percentage legislature of female legislators in the nation. Yeah, and it's very cool. But I'm also like in the same case where you have like majority female dominated professions, whether we're talking about teaching, whether we're talking about healthcare, right? Especially like nursing home and elder care. These are all predominantly women, and we are all expected to be martyrs and work for free or nothing. And so for me, it's also like an equity issue when we're talking about like equity in the workplace. And so I thank you for bringing that to everyone's like attention if they didn't know. There is something promising happening in the legislature as well. A group of women legislators have been working on a paid legislature for a handful of years now in the House and in the Senate. And they have just dropped not only the enabling legislation, but the constitutional amendment to make sure that we have a full-time paid professional legislature. And, it's one thing to get it through the legislature. It's another thing when it goes onto the ballot for the voters. Because you can bet your bottom dollar that everybody who does not want to see a professional legislature because there's an outsized corporate influence, lobbyist influence, because they're essentially the full-time paid legislators sometimes, you bet that they are going to fight against this tooth and nail because they don't want us making our own decisions. And so the entire campaign, I can guarantee you right now, as somebody who works in communications, is going to be, how dare these people pay themselves? And so when it comes to the constitutional amendment, we're really going to need your help because it's going to take neighbors talking to neighbors to talk about the fact that we actually need a professional legislature. So I hope that helps.
Any other questions from the audience?
I've been in healthcare for almost 20 years now, half of my life. And this isn't the first time that malpractice insurance has come up, nor has it been. Also, the other thing is shortages, physician shortages, anything like that, primary care. It's not the first time that it's happened nationally. It's been around for a really, really long time. So why now? Because I believe that one of the issues is that it happens during enrollment, meaning that when somebody wants to become a clinician, either a nurse practitioner, PA, physician, something like that, I think it happens there because it's so hard to become that person, right? And we've been talking about these shortages for a really long time, and I remember when we re-credentialed nurse practitioners and PAs to do more work, and providers were all up in arms. We don't want them doing that kind of work because they're not qualified. And so I think like why now that we're all so interested in this, because it's been around for a really, really long time, as long as the nurses shortages has started happening. So I just want to know your opinion on that.
I mean, I think we're hitting kind of a critical shortage. I think that's why it's come up now. Our board wanted us to look at this because it's become unavoidable. And something that I think is right on that Representative Anaya said is this has been impacting vulnerable populations for many, many years. It's now affecting everybody, right? And so you can't sort of buy your way into better healthcare in New Mexico anymore. It's just not available. And I think it has become such an unavoidable in-your-face issue that folks are now starting to say, okay, we can't deny that there's a problem. There's a dire shortage. What's causing it? What's going on? How do we fix it? And I think the legislature is laser focused on those issues right now because the shortage is so severe. And I really do think it's become kind of a vicious cycle that feeds on itself. Folks are so burned out that they're leaving because there's not enough physicians. And at that point, we're sort of in a death spiral. So we have to reverse the trend, get things back on track, which is why it is an all of the above approach and strategy. It's malpractice reform, it's compacts, it's student loan repayment, it's pipeline programs, it's ad residencies, it's all of these things.
It's affecting rich people.
Literally.
Yeah, I saw that with the drug problem when poor Hispanic people in Espanola were dying. Nobody seemed to care, but as soon as it started hitting the middle class in Albuquerque, suddenly there was funding and people cared about it. But I will say, I've been doing this 30 years, 40 if you include training, and this is worse. It's way worse than we used to be able to hire a physician fairly regularly. It's been, just very sparse over the last 5 to 10 years. We have, we've hired good people, but it's very, very hard. There's just not nearly as many available, so.
Yeah, I mean, I believe I brought this up in one of the committee meetings, but I don't even want to say rich people, but very specifically upper middle class white folks. It is now affecting them. And I say this as somebody who comes from a family, generations of New Mexicans who have been here and have lacked access to healthcare for a long time. And quite honestly, the relationship, the patient-provider relationship is also not there because of years of history of people of color honestly being experimented on, whether we're talking about reproductive healthcare or otherwise. And so like one of the things that I think of is historically here in our state, we have not necessarily had the best kumbaya relationship with providers. And a lot of our families will say, nope, we'll stick to our herbs, thank you very much. I'm sure you all have heard the Vicks joke. The Vicks fixes everything, right? But it's very true and it's very prevalent in our communities. And so I think that's one of the things that really irks me about why everyone is so concerned now. It's also one of the things that honestly gets under my skin when we talk about malpractice, because we've had this physician shortage, and not just physician, provider shortage for a long time. But it wasn't until it was in other people's interests to start talking about it that people started caring. And I do hear you, like it's worse, now than it's ever been. But I also think historically, right, if you look back into, I want to say the 80s, but it was the American Medical Association very specifically lobbied Congress to reduce the number of residencies because they wanted doctors to be able to be paid more. And so we are lacking residencies to this day as a result of that. And so I think like a lot of these things are being taken out of context, and I think it's really important to add the "and" right to what's happening right now. And then you just have like an affordability of going to college. Like quite honestly, who wants to go to college now? And who wants to go to college for like a whole host of years, right? And so I just think like there's like this confluence of situations that young people who are looking for careers are like, no thanks. Like that actually doesn't sound nice. I would like to not be in debt for a long time. And yeah. So anyway, I just think it's a whole confluence of things. But I really wanted to point specifically to the equity piece because it's part of something that really bothers me about this conversation that nobody ever talks about. So I really appreciate your question because a lot of folks don't ask that.
I'm just going to comment that I'm an upper middle class white person, and my physician retired. My primary physician retired a year and a half ago, and I have not been able to find a new one every time. I want somebody who's, enough younger than me that they're not going to retire, 2 years after I do. And the last 3 people I've been ready to call and say, hey, can I, they all left. It was like, told somebody, I'm going to call this person, and they're like, oh, they're leaving at the end of the month, and last 3. So I'm not going to do this to anybody else. I don't want them to keep leaving, so.
All right, we got one more question over here.
Yes, I just want to preface my question with that I do believe that the interstate compacts are needed. I'm all for it. But I attended a meeting where a senator said, if we pass the interstate compacts, there's also a big chance it makes it easier for our medical professionals to leave our state. How valid is that argument?
Well, the 2 things I would say about that is, one, we haven't seen that in any other state. So again, there are 42 states in the compacts, rich states and poor states. We haven't seen an influx, folks leaving the poor states, going to the rich states once they join the compact. We've seen overall, when a state joins, they get about a 10 to 15% bump in licensure every year. A lot of that is telehealth, but it's basically saying more folks are getting licensed in that state through the compact. And the second piece, unfortunately, I would say is doctors are leaving now. I mean, as we just said, not being in the compact honestly isn't a big barrier to leave, partly because we don't do a great job of licensing here. So we've heard from folks that say it's actually a lot easier and quicker to get licensed elsewhere. It's not a 6 to 8 month wait, which it often is here and really shouldn't be. But so I don't think, based on, again, experience elsewhere and what's going on now, joining the compacts is going to lead to an outflux of doctors. It will definitely make it easier for doctors to cross lines in both ways. But I think we probably don't want to be the 50th state left out of the compacts as everybody else gets in.
Yeah, I mean, I'll just add to that. I don't think it's going to cause a ton of people to leave or a ton of people to come, honestly. I do think it'll make those who want to come, it'll make it easier for them. And so to me, like, net gain in that sense. But I also think that, when we were passing the compacts in the healthcare committee, one of the things that we talked about was the need to attach data to this. Because right now, we've had the nursing compact for a whole host of years and nobody has any data on it. So we don't know whether we've lost, we don't know whether we've gained. We actually don't even know how many nurses are in the state of New Mexico practicing. We know how many are licensed. And so I think that is like part of, once again, not talking about things sweepingly, but to get really granular in what we're saying and what we're passing to say, what is the data that goes with this? Because I don't just want to know who's licensed here. I want to know who came here. I want to know who works here. I want to know who's in our community. And so I also really appreciate that question because, if we're just doing things for the sake of joining a bandwagon, which that was crass, sorry. But really, I just keep hearing, well, other states are doing it. And that's fine. But we do things different. We are protecting our people here. And I think that's really important. And so I don't want to do things just to join the bandwagon. I do want to do things that are actually substantial and meaningful and intentional to make sure that we're actually moving the dial. And so I'm a big proponent of attaching data, although I think it would also sink the bills because not everybody likes transparency, turns out. So I won't make any amendments.
Justin, you have raised your hand, and I'm going to let you speak.
I thought I would respond to the question as well. I'm not sure what argument they're making there. What these compacts will do will form a chain of strength between 42 other states and this one so that practitioners who have the desire to make a change for all of the populations we've discussed here, people who are very sharp and they realize they've been overlooked and neglected, that's what the compacts are going to allow people in need of care to interact with. I'd be more than happy to hear the logic behind that. I can't dissuade it, of course, but if you know any more details about it, please feel free to follow up with me. I'm interested in that topic. Those compacts are urgent. On the matter of keeping people not needing to frequently visit care providers, that came up at one point. I want to address that. From food systems development all the way to creating doctorate of nursing practice programs, other people are performing tasks in clinical settings and research settings too. So there are hybrid disciplines being formed where it relies on the public health sector to produce that data. So I'm going to go ahead and urge everyone to produce that data across multiple departments and universities. Thank you for bringing that up. Thank you for your question about the compacts.
Great. So I think we're going to wrap up now. You know, you've been. One more question? Is it quick?
I understand. I understand. Oh, no, it's me.
I understand that it's a double-edged sword, but as we live in Santa Fe County, we can see the development. And my question is, with the development, it's bringing people to New Mexico, which we know we're not going to stop because we live here too and we love it. So why wouldn't other people want to live here too? But the problem that we have, if we have this problem now, with all of the development that's taking place, how are we going to serve the influx of the new people that will be moving here? And are the developers doing anything to assist in helping with this problem?
That's a good one. I don't know. Does anyone?
Great question.
Are we talking about housing there are a lot of developers. Are we talking about housing developers?
Yes.
Okay, thank you. It's like, which developers are we talking about?
Yes.
I feel like, I was actually just talking to you about this. I went to undergrad at UT Austin, and I remember a lot of people saying, like, this is not the Austin it used to be. It's not as, unique. It's not as whatever. They had this gigantic boom, and then everything skyrocketed, right? And so I do think that we have to think about infrastructure. I also think that we need to be thinking about regulations as well. And I know you guys are going to be shocked, but like the ways in which these development corporations are actually investing in our community, specifically with like affordable housing as well, to make sure that the people who are here already are housed, because we have a big homelessness issue. And then when we can do that, then I think we can figure out regulations to make sure that we are like expanding for other folks as well.
Can I have
Okay.
a comment to that really quick? I just want to tell you a really quick story. I promise it won't take long.
We were trying to recruit a physician from Seattle, right? And we were giving him a tour of Albuquerque, Santa Fe, and everywhere else. And his one comment was like, he was like, I don't want to live in one of those mud houses. So I think we need like my point is I think we need a whole rebrand as a state, because we have more than just like mud houses and stuff and stuff like that. So it's a whole thing. So that was the whole reason why he didn't want to come here, is because we obviously live in mud houses.
Or embrace the mud house.
Yeah, I was like,
Hey, if you're not down with the brown, get out of town.
All right. On that note, we are going to wrap up. Thank you so much for joining us. We know this has been a long evening with a lot of information, not always the most exciting, but very important. No, I mean, you know it. Okay. So we want to thank the Jean Cocteau, who gives us this space for free. So yeah, give them some love, buy some drinks.
Thank you.
And you want to go to the next slide? Just another plug. Oh.
I would, but it just crashed. Basically, subscribe to our newsletter, 505omatic.com. Thanks again to our panel. You guys have been wonderful.
Thank you so much.
Oh, please take selfies, tag us. And thank you to the audience. Thank you to you, sir, for saving my wine glass from falling to its death, which would have just been terrible in that moment. And thank you, Katie, for your charger.
Oh, you're welcome. Was that nice?
And the people on the live stream.
And the people on the live stream.
Thank you for tuning in, live streamers. Okay,
Bye.
good night.
Thank you, good night.
Well, those who tuned back in after the camera died.
Yes.
We got up to like 18, 19, but total viewers was like 40 something, which was like nice. But then the power cable wasn't fully plugged into a thing.
Oh yeah, so it cut out.
So it cut out.